in the beginning, my first idea of leadership, of course, was a sailing boat. Yeah? You cannot run a sailing boat yourself. You need good sailors, but there need to be a captain somehow.
We had some very interesting discussions in the recent years about digital toys that we both are very passionate about. Where does this curiosity come from, Bilal?
We are all sure that the big revolution in medicine and dentistry will come from this. And I always tell my young students, if somebody just shows you nice results, don't trust it. So there is a certain failure rate. We learn from this, and so you should be self-critical.
Welcome to Straumann ProTalk. Welcome to the Pulse of Dentistry. My name is Raeber, and together with Andreas, we are really pleased and also honored to have Professor Dr. Bilal Al-Nawas here with us today. Welcome, Bilal.
Hello, welcome.
It's really a great honor to have you here. We had a lot of contact, and for the audience, what you can learn today is actually from one of the leading oromaxillofacial surgeons to hear about very complex surgeries, often about patients that have actually tumors and that need massive reconstructions. We're going to talk about the tools that Bilal is using for helping those patients. Secondly, we want to discuss on a more lighter side about digital dentistry. I know you are very playful with digital, and we are certainly going to touch upon this and how it's actually going to change how we do dentistry in a few years from now. And then last but not least, very importantly, we also want to talk about education. Bilal, you are a very dedicated and passionate educator, and we're going to talk about this, the ITI, and also the impact it's going to have on the younger generation, how important education actually is. So Bilal, for those that don't know you that well already, who are you in just 1 minute?
Yeah, my name is Bilal Al-Nawas, a typical German name. No, my father came from Iraq, I think 60 years ago, and my mother's German, so I'm really half and half somehow. And I'm a teacher at the university full-time. I studied medicine and dentistry, and now I am the head of the Department of Oral and Maxillofacial Surgery in Mainz.
Very short and sweet. So as you mentioned, you are a medical doctor and a dentist. And for Germany, this is a prerequisite for oral maxillofacial surgery. But that's not the case globally. So I would just like to kick out with the question, how did it actually influence you? So you have both in you, medical doctor, but also dentist. How did it change how you look at patients today? How you do treatments? And which side is important in which cases?
That's an important question. My father was a dentist, and I studied dentistry first. So deep in my heart, I'm a dentist. But when I come to a hospital and there are the main problems, the big problems, I feel a little bit at home. Yeah, and so I think modern dentistry requires a lot of medical skills because patients get older, they are compromised, and also the dentist in the private office has to reach these patients somehow. On the other hand, what we are doing in the dental field influences the medical part. And I think even in future, there will be much more things happening on this interaction. And somebody has to speak both languages. So you need to be both to tell the medical doctors that dentistry is important, because no medical doctor looks into the mouth. And also the other way around, when the dentists are there, somebody has to translate the complicated things into, let's say, the surgical dental part.
Maybe to extend on this, in the US it's different. So you don't need to have this, let's say, medical degree. How do you see the differences in how patients are treated?
That's a little bit of political. You know where it came from? It came from the First World War when patients came back with severe injuries of the face. Nobody could treat them, but dentists could, because they used the methods of dentistry to reshape the face, like prosthetics. And they said, okay, we have to study medicine. That's why most of the OMS departments in Germany are allocated in the dental school. Yeah, so it came via the dental field. And so in Germany, we are much more involved into the dental part. And when we, for instance, treat a tumor for cancer, we plan the reconstruction, the tooth, before we resect the jaw. Yeah, so In the US, it's totally different. So usually the big surgery is done by head and neck surgeons, or cleft surgery is done by plastic surgeons. And so in Germany, this is a little bit more integrated into dentistry. That's how we think, a little bit different.
Bilal, Mainz is your home since a long time, for 15 years plus. You are leading person or the leading person in the department in the University of Mainz. I mean, what made you choose the academic path in the first instance?
That's a very interesting question, because I always wanted to become a private practitioner. You know, I went into the conferences, and there in the parking lot, you see the very nice Porsche cars and 10 cool doctors. These were usually the private practitioners, and usually the pale, hardworking. So these were usually people coming from university. I thought, which will become my way? And then I already had an idea where I wanted to go. And then came the ITI World Conference in San Diego. And I had a little lecture, I think 15 minutes, and was in front of a big audience, 800 people, translated into 7 languages. And on this stage, I really felt at home. On the way back, my former professor, Wilfried Wagner, he took me even in the airplane. I said, Bilal, you have to reconsider going into private practice, perhaps university.
Readjust your priorities.
Readjust your priorities, yeah. And so I said, okay, this is a good option.
So he realized there's a window of opportunity and made use of it. And then
it is, yeah. You should strengthen the strength.
Yeah, absolutely. Yeah. And now you have a big impact on the department in Mainz since a long time. What makes Mainz so specific? You know, I mean, not only your department in specific, but the whole university and also the ecosystem around companies like BioNTech. Do you realize something like this?
We do. There are so many aspects. So we had an OMS professor there for many years, Wilfried Wagner, who was very much attached to dentistry and plays an influential role still in implantology. So there's a long background attachment between the dental school and the OMS department. That's not normal. So usually this is more separated. We have the airport there very close. That means we are always quite international. So Frankfurt is 20 minutes away. We always had the interaction, one of the earliest scholarship centers there. So it's very easy to reach. And of course, the whole university now is shifting to immunology. With BioNTech, the 2 founders were part of our internal medical department. We have good relationships. And of course, if you do something with immunology there, every door is open. Yeah, so I think it's a good setting. And now with Samir Abu Ayash as prosthodontic, we have a very good team. So the master program in implantology is international. We're trying to open up the German-speaking, a little bit closed universities, a little bit more to the international part now.
Okay.
Bilal, your daily work covers probably some of the most complex, let's say, OMF surgeries that can be done. And I had the chance actually to visit you on several locations and also participate in some of these surgeries. And for me, it was very impressive on what actually can be done. And I think the way how you change also the course of the patient's life is amazing, because these are large reconstructions, and without them, I think the quality of life for these patients, they would be just really, really lower than what the outcome allows. Now, a part of this spectrum also involves specialty implants. Of course, this is something that we would like to discuss a bit. And you have been very at the forefront of also defining the usage of these specialty implants, be it now short implants, small diameter implants, zygomatic implants. We discussed about subperiosteal implants. And I think this is now a topic that we would like to deep dive a little bit into. Could you start with just describing maybe one of the cases that were really some of your most complicated cases? What made them complicated, and what did you learn by actually treating the patient?
Yeah, there's so many, but to make it clear, so we do everything. We do undergraduate teaching where we treat simple cases also, but as you said, the most influential things we can change are those complex situations where really a team approach is needed. Often even the orthodontist is part of the team, the prosthodontist is part of the team. And one of the situations I can remember, that was a 90-year-old lady where we did a resection of the jaw, and the anesthesiologist said, so this was close to what we can ever do. We will never do general anesthesia in her again because it's so difficult. But the problem was she had no reconstruction. So there was an open, large fistula to the nose. How can she eat now? And at that time, we were discussing different options. The jawbone was nearly gone. And she had one of the first subperiosteal implants, but the problem was I had to bring this in local anesthesia. So I made the deal with the patient. She was still so clever, said, this is one option we have and you have to stand it somehow. And we both were sweating. The patient was sweating. I was sweating. I cut a little bit away, don't tell anybody, of the subperiosteal implant. But the funny thing is now she's still wearing this without teeth. It's just closed, but she says, I'm happy with that. I can eat, and this thing, this device is still there. And without this option, there was technology, but there was also the empathy and the emotional interaction with the patient. And I still love it when she comes back for recall now.
I think even with those, or even more with those very large interventions, I think the link to the patient is extremely important, and probably you see also these patients over a long period. It's not a standard treatment that gets referred to you. You place an implant and probably you don't see them anymore. But it's like you really walk a part of their life, which is probably one of the most difficult ones together.
It is the case. We have this with the oncological patients. Usually they come for the follow-up and sometimes they need the attachment. We have this also with the children. When we operate a cleft palate, you are part of the family forever. And it's the same with the reconstruction, because we have nice conferences with red and white aesthetics and everything, but some patients, they will not find help in this standard system. And when you can offer them this by a good team approach and good technology at the end, you'll be attached forever.
Bilal, I'd like to come back to your patient, and you mentioned you placed a subperiosteal implant at that stage, and this is a topic that we see kind of coming back, but we know it has a long history and a very controversial history, with a lot of complications in the early stages of subperiosteal implants. Now we see it coming back with new technology, new imaging technology, planification, 3D printing. How do you look at this? How do you see the potential of this? Is it like really a future solution for, let's say, that is much needed for some patients? Or are we repeating old mistakes?
Hopefully not. The point is German surgeons are always a little bit critical. Usually if you see such a new device, you always think, this cannot work.
And they saw it before.
Yeah, we saw it before. It will not work. But the point is, then you come to these patients like the elderly lady where you say, okay, this is the right person. This is why often surgeons believe in this, let's say, niche implants, because this is a solution for this special implant, this special patient. And so we tried it in a few patients. It worked well. We did a systematic review on it, and the outcomes are not that bad. So the technology is not comparable what was available earlier. So with the digital technology, this is a clear, let's say, step ahead. And I'm fully convinced that especially in the atrophic jaw, the severely atrophic jaw, this will be a very good option. The point is a little bit the critical point. It's even a little bit too easy to insert. The Zygoma,
too easy.
Yeah, everybody can do it. The Zygoma implant is difficult, so it will be reserved for specialists, and these specialists usually know what they do. So that's fine. The subperiosteal implant is something you can plan. It's backward planned, and you screw it in. You have to open the flap and close it again. But there's so many things to consider. The soft tissue, different biomechanical aspects. So I think it's even a little bit more dangerous because of the side effects we cannot control yet properly. Soft tissue coverage and all these things. But the technology is something which will not disappear, I'm sure.
You did this systematic review on subperiosteal implants. How much have you been surprised about the actually quite positive outcomes of it?
I was quite surprised by that, especially as we have different companies coming in. We have some companies who do it in a very structured, I would say typical German way, very strong structures. We have others who produce very delicate small implants. We have others who treat do different surface treatment. And it was very interesting that there's some common sense behind it, and there are also some differences. So the next step will be to bring this common sense together and try to bring out an educational message, what is needed.
Can I add one question? How much do you see it in the future also outside of a hospital setup, like in private practice? Because, for you, if you have an orbital reconstruction to be done, I mean, you use the same technology and it's not, attached to let's say, a tooth structure. So for you, it's very natural to use this. But how much would you see this outside of a university setup?
There's an easy example, and this is the 3D printed titanium meshes. Everybody in the private setting who does a lot of augmentation procedure is using these meshes in certain indications. And so I'm sure that also subperiosteal implants for specialized centers, for people who have, let's say, outpatient general anesthesia available, will use it.
Okay. How do you distinguish subperiosteal implants from zygomatic implants, and what comes first, maybe what comes later? Because also the zygomatic implants, there's some kind of a rescue system after very severe atrophies happened. How do you position SPIs versus zygomatic and other treatments?
George, I waited for this question.
You waited for this question?
Yeah. I think the zygomatic implants requires quite a lot of skills. If you have these skills and if you know how to do them, why should you use the subperiosteal implants? So these people, they are good and they produce perfect results. We saw this also in our consensus conference. But the learning curve of the zygomatic implants is not very fast. And of course, you have a little bit a different setup of complications there. You're close to the orbit. On the other hand, the subperiosteal implants are very close in the indication. But I think there will be different group of people using it. They will be both together. It should be more when you do the teaching, if you are the patient, what would be your first option? You can tell me later when the mic is off.
I hope I'm never going to need one of them, but I don't know. Yeah, but it's interesting. So on one hand, you say it's easy to be placed, but obviously it seems also to be not so easy to have the right patient selection, and maybe that also drives then who uses what. So private practice versus clinical setting. How do you foresee the future of the usage of those two tools?
If you do such a subperiosteal implant, it's quite easy because you do a scan, you do a backward planning, and these 3D printed items, they fit perfectly. So you just need to raise a flap and put it in. So from my point of view, it's even too easy. So if you have a hammer, everything feels like a nail. And that means finding the right indication and not overextending the indication. Still, we have the sinus floor elevation. Still, we can do all-on-4 or pro-arch concepts. So that means I would see more the risk that people overextend the use because it's so easy and fast. So we'll have to balance not against the zygomatic implants, we have to balance against the standard concept. Which patient benefits from a standard sinus floor elevation and 4 or 6 implants compared to subperiosteal immediate loading?
Where do you see the biggest risks if it's overused? Is it the soft tissue complications?
Yeah, it's soft tissue. The problem is you have a full metal framework, and if you have an infection there, it might be difficult to get rid of it. And if you have an infection, you will lose a lot of the bone. That's a little bit tricky.
And probably we need to gain a bit this long-term data back, which is now with different technologies. It's not the same as we had before. So probably there needs to be some cases, some long-term.
Yeah, and I want to hear about the complications also. It's not about talking how to do this and how to bring it in. It works. The survival rate is good. I want to see how to deal with complications. How can we treat a peri-implantitis in a subperiosteal implant? What soft tissue procedures do I have to do to, let's say, prevent this situation? So these are the interesting items. ITI comes back to answer
exactly.
that.
It's not just about device. It's like how to use it. Maybe let's dive a little bit more into zygomatic implants. So Bilal, there has also been quite involvement in zygomatic implants. What did you, let's say, observe in the last 10, 20 years, so 2 decades of how it evolved? Where is it today and how could it look in the future? Is it an indication that grows? Is it something that has reached a plateau? Do we need new technologies associated with zygomatic implants?
Yeah, we started very early when they came to the market. And I know that my former professor, he went to Sweden to get the training there, and it was always an exciting procedure to do with these 5 centimeter long implants. And the interesting thing is when Straumann came back to the market, we recalled the old patients, and we still have some of these 20-year reconstructions working. And I was so surprised that you can have such a long-term stability with these indications. And interestingly, especially the oncological patients, they benefited quite a lot. And so you have to say that when we reconstruct the maxilla, it can be after severe atrophy, it can be after trauma or oncology. This is always a question. Should we do this using some grafts from the hip, which is complicated, or should we do it with implants? And there, also for atrophy, the Zygoma implant plays a role. And I think when you know how to do it, you can really reach nice results. That was a good learning for me. And I really respect the group we had together for the consensus conference.
23, yeah.
That was amazing.
What was the main outcome there? So when you maybe can summarize for the listeners.
The main outcome was that we were fighting each other. It was one of the hardest consensus conferences ever. And I think when we met in Frankfurt at that time, we really found a kind of consensus. We saw that we can agree on certain procedures, and that showed me, sorry for that, the importance of the university and the ITI, because the company has a tool, has an implant, and I think you need also the interaction with a group like the ITI to define these settings. And that was for me the eye-opener in Frankfurt.
I can imagine it must have been quite hard. There is a lot of, let's say, particular KOLs that play in that space that are important. So.
I still love them all.
You still love them all.
So is the next consensus conference that we need how to position zygomatic implants relative to the use of subperiosteal implants? Or
somehow we should talk about the subperiosteal implants because they look so different, and we have to define somehow the indications, and I think they will live side by side. You don't need to balance them against each other.
Yeah. Bilal, there was a study that you participated in that was a very interesting one, looking at 20 years success and survival rate of dental implants. And, I think it's always a bit surprising if we reflect back on the history of dental implants. It's not like 70 or 80 years old. It's I think we have data. 20 years is a lot of data, right? So what did you learn in this study, and what were your key takeaways, let's say, on the implant side, the material, but also for the clinicians and the responsibilities clinicians have?
Yeah, this is always for us also an eye-opener when these patients come back. So I have some patients at my university, before the one like Wilfried Wagner, Professor Teach, he started with IMZ implants in the 80s. So I have patients coming back to my department with implants from the 80s. Please find a screwdriver for that. Yeah. So, but they still work. That seems the first thing what as company we have most of the complications in the beginning. But when you have the implants in for 10 years, then you have a kind of steady state there. And I think this is something we have to learn a little bit. And that's why we are more also looking at the immunological part. Why is this working in certain patients and why not? It cannot be only the periodontal disease. The other point is that we learned from these long-term studies that some of the, let's say, reconstructions we did, which were borderline, still work on the long term, like reduced diameter implants, shorter diameter implants, situations where we thought was a compromise, they still work. So, and the other point is, of course, that the implants 20 years ago looked different. So they're not on the market anymore.
So what mindset shift would you wish younger clinicians actually to do based on those kind of long-term data? Is there a misconception that you actually would like to, get rid of?
Yeah, the misconception is coming a little bit from the, let's say, conferences we are doing also as societies, things always look easy and everything ends up very nice. And I should be self-critical when you treat your patients. I always tell my young students, if somebody just shows you nice results, don't trust it. If I want to see on the big stage also a failure. So there is a certain failure rate. We learn from this. And so you should be self-critical. Ike Schignetz is now always discussing the debriefing. Yeah? When you do the surgery, come back and think, what should I do better next time? And so I think learning and also being self-critical with the procedures you are using, that's so important.
Bilal, I would like to speak also about your leadership in Mainz, because I know a lot of your people and I realize there's something special about this. What is your leadership mantra? You know, in this setting, as you have to collaborate on very complex cases with a lot of different specialties for the greater good of a patient ultimately. So how do you approach leadership?
Yeah, now you're touching the secrets. Yeah, I see that. Yeah, in the beginning, my first idea of leadership, of course, was a sailing boat. Yeah, you cannot run a sailing boat yourself. You need good sailors, but there need to be a captain somehow. But there is also another point, and this is an interesting aspect also in surgery where people are powerful. Yeah, and I always like the idea of the tribe. So how is the leader in a rural society or in a pirate boat? Who elects the captain in the pirate boat? They will not fight for it. The strong pirates think, Andreas, he can lead the team. So I think to stand in such a strong community, like with strong surgeons around you, you have to build up this trust. You have to show them the direction somehow. But there are situations where you have to step in, take the scalpel and cut. Yeah, it's a very delicate balance.
I can imagine. No? And I see that you help also young talents to develop and you give them the room also.
Yeah, that's the future. Yeah. When I go to the lecture hall and I see these young dentists sitting there and I see the glance in their eyes and I think, look, the future is bright. It's happening. I just have to, they even know how the future looks like. They just cannot tell me, but I just have to listen to them.
Yeah, let's switch gears to digital dentistry. I think that's a good segue into it.
So you are very digital, and we had some very interesting discussions in the recent years about also digital toys that we both are very passionate about. So where does this curiosity come from, Bilal, that you want to try those kind of digital tools for the future also in your, let's say, clinical reality?
It's very simple. I had an Apple IIe computer when I was young.
Exactly, with a screen like this.
Yeah, and a floppy disk. Nobody knows what it is anymore.
Still
no, I think we are all sure that the big revolution in medicine and dentistry will come from this. And I'm totally addicted to the idea that they can make the treatment easier and more predictable. A very simple thing is think of backward planning. Somebody told me once that the biggest lie of the last 10 years, because that means I promise you as a surgeon, you can ask as a prosthodontist, where do you want the implant? And I give you this position. I build up bone like a miracle. This is not true. You need two eyes and you need both. And the digital planning helps you so much with that. What does it mean? It reduces the burden of care. Very simple. And this changed so much for us. And you see this in so many fields of if you do now, let's say, a jaw reconstruction, orthognathic surgery, jaw advancement, we would never plan this without digital tools now. No plaster anymore. Perfect.
Yeah, so it's really the intersection that you can discuss together basically from a prosthetic viewpoint, but also from a surgical. What is a feasible, I would say, treatment plan?
Think of the next disruptive part in education. Of course, I will wear, you call it point of view nowadays, a glass, and you can come with me to the surgical theater, or I can assist you when you do the operations. So there are so many things happening in this field, and I want to be part of it.
Which part of the digital ecosystem, in your view, is the most underdeveloped? So where should we put a lot of focus to further advance?
You mean we as company, or we as...
We as being part of, let's say, a common, I would say, medical field, but maybe also as company.
Yeah, I think the next major step when you look at the medical field is quite obvious, and this is individualization. You would call it personalization. When we think of the question was subperiosteal or Zygomatic implants, short implants versus bone augmentation, we decide on a basis like this. But when you think of the company, you have on file all the different fracture modes for the different components. You can tell exactly this component can be suitable in this individual situation. In the future, we will learn about the chewing forces of the patient. So we will come, I'm sure that we will still live that to an individual recommendation, not the digital twin, but something like this, where we'll simulate the situation. We know that already for the subperiosteal implants, some of the companies, they simulate some individual situations, and we will come to that also in dentistry, I'm sure.
Yeah, I like that a lot because it's some of the stringent data sets that are missing is still chewing force. It sounds weird, but we don't have a lot of data on chewing force, and let alone individualized data. So how do you chew, and what does it actually mean for the ideal reconstruction?
It's still an expert system, but I think there a lot will come.
We need to create the measurement devices that actually can take the data. You're also very, I would say, advanced in dynamic navigation in digital surgery, and I saw you performing some surgeries that you actually took in neurological guiding systems that actually you then used also for dental. How do you see this field develop? How important is it for the future of dentistry? Dynamic navigation and maybe even robotics?
You come back to the point, why should you study medicine and dentistry? Because you can do the transport of the technology in a certain way. I bring the piezo surgery to the neurosurgical department, but of course we also bring the brain lab to the dentistry field. And I'm sure that this field is totally underestimated in dentistry. I just discussed this. It's not about drilling a hole into bone. It's more about when you know where you are, what you're doing, you can have a plan and you can superimpose this plan. And this is more than you can estimate. And I'm sure that this is something which will open doors in dentistry. So you can design your restoration and you can prepare the tooth situation. You can prepare everything according to that.
Maybe to extend this a bit, because I think it's fascinating that still it takes quite a long time for these technologies to be adapted in dentistry. If you compare it to orthopedics or neurosurgery, dentistry lags behind, but it's often not a, let's say, life or death question. So why is that? What is there, let's say, is it working too good so that these technologies are actually then faster adopted, or where is this coming from?
So in the medical field, often the driving force is the OR time, which is quite costly because you don't have nurses. It's not even a question of money. And that means if you have a technology making the OR faster and more predictable, this will be a breakthrough. In the dental office, planning and calibrating these tools is still an issue. And I think as soon as we see that these tools are being more easy to use, then they will be adopted. But dentists also love technology. And I'm sure when you see with the scanner systems, with the intraoral scanners, it took, I think, 10 years, nothing was really happening in that field. And now
it really takes
everybody has a scanner. And I think we will see this with dynamic navigation also. If you think of a surgical center, maxillofacial private office, they will have these digital tools.
Bilal, I know you also as a very visionary person, a creative person. How do you envision the future of implant dentistry in 10 years from now? Bringing it all together.
Yeah,
your dream setting. Basically.
My dream setting. Yeah. No, my dream setting is, of course, a very, let's say, individual setting. That means I will have my data set of my teeth preserved digital. When I lose these teeth, we know that people get older with more teeth, so there will be less denture, complete denture, more elderly patients having teeth, and I would like to have this restored using my individual data set. And you as a company will provide the background data for that, and we will simulate which implant is the best. And I think this is, this development is clear, and I'm also very convinced that we will work with much more smart devices. So we'll not just put a crown in. So I'm perhaps prone to periodontal disease. Some people wear these glucose sensors. Why shouldn't they wear a crown monitoring MMP8? Of course, it's silly. I can use a probe. Of course, I know when I eat that my glucose is rising, but people like to see it. And
you cannot measure all the time MMP8. So today, so you need to go to the dentist basically. And
that's it. And I think these monitoring devices, wearables, they will be also something which we will see in implantology, and this will help to bring also individual conclusions and individual treatment plans, but also in the long term to make it more safe.
It makes a big impact if you get a notification on your smartwatch on this.
It does. It does. This is
it truly does.
Yeah.
No, thanks for sharing this, Bilal. And I think we also have to speak about your deep motivation of enabling others and teaching others and being active in associations such as the DGI and the ITI. You mentioned this before. The ITI has obviously, changed a little bit, the path forward, as you saw it, not going into private practice, but ultimately staying at the university. And you've been very active in the ITI in the following years. You had a huge influence in the ITI in Germany. You had an influence in the ITI being member of global committees, then leading the research committee, and with this also being one of the board members in the ITI globally. So one of the top 4 people leading an organization of 25,000 people, wow. Which is sounds big now, right?
If you tell it like this,
this is what it is. And I mean, Bilal, if you look on the ITI, how do you see, especially young clinicians, but clinicians in general, benefiting from the ITI?
It is still a very special organization because it's so big and global. It's well recognized, and it's very interesting that it's close to a company, but still, if you say I have an ITI grant, it's valuable. Yeah, and this is a balance which you cannot buy for money. So perhaps to put it in a broader context, I like the interaction between a company with a certain mindset, we want to earn money, but also having the ITI like in a good marriage, we go into the same direction, sometimes with different viewpoint. And I think from the perspective of young clinicians who have to still stand in a university setting where some people say, oh, this is too close to a company, helps us to give them this playground. You can put it to my perspective. If you start the German leadership part and everything, you want to be creative and you need this setting. Some people who help you to start a new, let's say, meeting or a new format of education. This is nothing I can do. I can have the idea, but when they are in the background professionals like the ITI who can help you, you can move things. Like the young ITI in Germany, we started more than 25 years ago. So that's why the ITI can play a big role for young clinicians who want to play a larger role. And I know that the ITI is opening up more for this talent search. Mm-hmm. And if you have young talents, they are very open-minded to integrate them. And I think that's why it's still important to have it.
And Mainz is also a scholarship center. You mentioned this, right? So how many scholars did you already have in Mainz? Do you know?
Oh, I cannot count. No. I think we had from every continent.
15. Okay.
Yeah, something.
And how do they influence you in your department? I mean, they come from all over the world, come to Mainz. They must also influence.
This goes in both directions. For me, the most important thing is that when they go back, we help them to establish themselves in their country. So usually we try that they get a grant, also an ITI grant, that they write a paper, and we try to visit them in their country to help them to find their way, which is sometimes not easy. On the other hand, we have long-term relationships. So I will fly to Korea next week to visit Yongdae Kwon, who was a former scholar, and I'm now guest professor at his department. Mm-hmm. So we are like friends. Yeah. And my dream is that we can open this relationship also to other younger people. But of course, for our department, it opens up also our horizon. We now have a master program in English. I think this would not happen without the ITI scholarship program.
Okay. Then, Bill, I think one very important role you had was leading the global research committee. I mean, I would say there are two big legs that the ITI is really standing on. One is education and one is research, probably first research and then education. In your, let's say, period as a chair of the research committee, what is the achievement that you have been most proud about?
Yeah, that was an interesting question because most people, even at that time, thought ITI is mainly for education and we can just stop the research because this is done by the company. They're just spending money. And so I tried to explain to the board, to everybody, that research is shaping careers. And behind every research grant, there is a person, there's a background. And so what we did is we opened this up to several pillars, like research communication, starting to tell the story about it. So it's very interesting to look, what is he doing in his lab and why is he doing that? Another aspect is the unique situation between ITI and Straumann. So I would say ITI can do research you are interested in, but you cannot do yourself. So if we align on this can be very open. There's nothing to be hidden. And I like this delicate situation between a private company and a scientific society.
Yeah, I can confirm that. I mean, you opened up, I think, a lot of the possibilities to strengthen the collaboration. And I think that also on our end has had an important impact on aligning basically, what we are doing, what the ITI is doing.
This is so important because we have different viewpoints on the same topic. Mm-hmm. And I think it's so important that we talk to each other because then we can move this into the same direction. That was a little bit missing beforehand. And I like this alignment. Mm-hmm. And I also like this delicate balance between a company and a scientific society.
No, but this is where I think it gets interesting, these conversations and discourses we have on topic, because without research there is no true innovation. So I think we really need each other, and I think we cannot continue innovating same pace and same impact without doing the fundamental research behind them. Bilal, teaching is also very close to your heart, and you received actually the award for being the best teacher in the University of Mainz, I think twice. And you have seen, let's say, a couple of years and generations of, students coming your way. What differences, let's say, what developments did you observe? How are the young students different than maybe they have been 15 years ago? And what is the developments you're observing, for the good and the bad?
The whole field is developing. When I now open up the newspaper of the examinees, they make their let's see, funny journal. I'm no longer the best. Ike took over. I think this is normal. But now I became student dean of the whole medical faculty. So I'm responsible for 4,000 students. And I still, if you wake me up at night, teaching is my dedication. And but still, these young students, they like to learn something. They like to see role models. And I believe if a lecture is good, they will come. So we are just renovating the whole medical curriculum in Mainz now. We are renovating a little bit the way how to do digital teaching for the DGI, because I think the next generation, they will have different accessibility, different attitude towards learning. They will not buy a textbook. They will buy a textbook, but for a different reason than we did. And a good example is if you want to just fix something in your vacuum cleaner, what would you do? You go to YouTube, you will check the video, you will
exactly.
fix it.
Exactly.
Yeah. If these young people, they want to do surgery, they go to YouTube. Hopefully it's a good lecture. So we need to provide good digital content on one hand, and we also need to provide comprehensive learning. And so I think this is a big obligation for us to offer this and to shape this a little bit.
Mm-hmm. Bilal, we also have the possibilities that the audience can ask questions. And actually, we received here a very interesting question. So what's one belief about implant dentistry you held early on in your career that you no longer believe in today?
That's quite a difficult question because it's more a development than a belief. I think I was taught that this implant is screwed into bone and then it's fixed there. It was a very mechanical aspect. And the belief now is that we are shifting to the term called osteoimmunology, that things are happening around, which are, let's say, balancing the fate of this implant. So we are thinking much more of the biological context this implant is in as being active. Yeah? So I was raised in a very passive world. So put an implant in, 6 months of healing, and then everything is fine. If you clean it properly, it will stay there forever.
Stay forever, exactly.
Yeah. And I like this biological context, and I'm sure that we will dive deeper into this in the future.
Very good. So now it brings us already to the last part, and here we also have a little, let's say, ritual. We also would like to give you the possibility to ask us a question, and what would it be?
The interesting thing is that in implant dentistry, you are a real global player. And so there comes also some responsibility. Do you feel that you as a big company, as a main player, have a certain responsibility amongst teaching and dentistry and also amongst your relationship to the ITI, perhaps?
Absolutely, yes. I think, as a matter of fact, just this year and then last year, we reflected on our role in education again. I mean, we've always put a lot of emphasis in this, but, every now and then you have to question it. And we came to the same conclusion again that, education is absolutely strategic to us as a company because we have a responsibility to make sure that young people get into implantology and, do this well with quality, and depth and, that they start their first cases with success. And not only the case number 30 or 50, but really start from the beginning. And there, obviously, partnering with the ITI is very powerful because, we are the industry. We cannot educate. We need clinicians that educate clinicians or researchers that educate clinicians. And then I think the second big topic is also, still keeping educating advanced procedures because the learning doesn't stop, once you have placed your first, 200 implants. But then, you as a clinician and you go through a learning curve and you conquer more and more indications and techniques. And we also commit ourselves also to let's say, continuously educate every clinician to master new techniques like whatever, a sinus lift, a new workflow, whatever it might be, a new technology, also to be there. I think that's a very important field for us.
And I think it's a very strong symbiosis also with the ITI and the consensus conferences. So we touched before upon, the topic Zygomatic versus SPI. I mean, it's just a little nugget, but I think it's so important that we are part of this, not over-promising and also putting it into the right hands to say, well, this is how you make your patient selection. This is actually, the best way to treat because that's the science behind, and we know it. And I think that's a very privileged situation that we have Straumann plus ITI to also be at the forefront for education. So.
And also, maybe to add the last point, also to support associations like the DGI in Germany, the EAO. I mean, I think we should be very fortunate that we have associations like this that, put a lot of effort and a lot of money actually in education. I mean, when we see those congresses, we see the courses, the curricula you're doing, podcasts, whatever formats, you are very creative about this. And, I think we should feel fortunate about this. And, supporting those is also super important because, they are very close at the doorstep of the clinicians.
So thanks a lot, Bilal, already for a very, very interesting conversation that we could have with you. Now, Andreas, how would you summarize what we discussed in this episode? It's
impossible to summarize, Bilal, in 1 minute. No, thanks a lot, Bilal, for coming over. And I would start with, this deep responsibility that you feel for the patients you're treating, very complex patients that come your way. And, you said it, you embark a team around a patient and, you want to do the best for the patient. And I think still keeping an open mindset, that's what really impresses me. You keep an open mindset on technology, new tools, digital stuff, SPI, to approach it openly, but then put data behind, science behind, and make sure this tool really, in a, let's say, evidence-based way finds its place. But you're not saying no from the beginning, but your first instinct is always open, and then you put the data behind. And I really like this. And I think the fundament of all of this is your curiosity, Bilal. I mean, you're a very curious
and
person.
Playfulness, I would say. Yeah.
Playfulness and curiosity. You like actually when new tools are coming and you have this curiosity and you want to learn more. And I think this is, I think where the whole journey starts. And I think, Bilal, what's impressed me today and also how I knew in the past is, your deep motivation also to teach and to enable others and the young generation to really, help them being great clinicians, because you are only one, you can treat one patient at a time, but this motivation also to multiply and to help others also to do great clinical work. So thanks a lot for sharing today, Bilal.
Thank you. It was a pleasure to talk to you both.
Excellent summary. Thanks a lot, Andreas. Again, thanks a lot, Bilal, for joining us here. It was a great pleasure. So to our audience, I hope that we could spark some new ideas with this episode. If you liked it, please leave us a message. Please check out the different channels. There is more episodes coming, and there is already a quite large, let's say, stash of episodes that you can rewatch, and watch out for the next episode. Thanks a lot.